And I'm going to talk about enteral nutrition. Hey, how about that for appropriateness? So, by the way, yeah, I'm from the University of Tennessee, but I am not originally from Tennessee. Some people are like, you don't sound like you're from Tennessee. Well, I live in Tennessee now, but I'm not originally from Tennessee, all right? All right, so how to feed, all right? Well, again, one of the speakers has already mentioned this, and as Dr. Kokocious pointed out, repetition is one of the best ways to learn. We want to learn by osmosis. I actually tried, at one point putting a textbook under my pillow, and it really didn't help me learn it any better. But I did get more studying done because I couldn't sleep nearly as well. When you're talking about enteral feedings, of course, we're going to talk about the least invasive to the most invasive, and that's what most people recommend. Again, nobody studied this because it'd be tough to study because it's so logical. Basically, you start off orally. All right, you pick up your bag with the intercontinental symbol on the outside. All right, you sit at your table and you start eating. Now, the first simple thing to do if the patient isn't gaining weight well is to try to increase the caloric density somehow. All right, you put more butter on it. You pick things with a higher caloric content. Instead of having fruit for dessert, you have cheesecake. There are all sorts of choices and selections you can make. Then the next step up is still oral, but you start supplementing. You use some formulas and some different supplemental compounds to increase the caloric intake. Next, if you're just not doing it with that, is to think about nasogastric tube, all right? Well, even there's a hierarchy. You start off with bolus. Nipple gavage approach is one of my favorites, especially for infants. You set a goal and a time limit. All right, because it becomes counterproductive after a certain amount of time. Basically, you have them feed as much as possible, and then you gavage the remainder. And again, the idea is you try to keep them on a normal kind of a feeding schedule. You want them to do as much as they can orally. Of course, all of these have the caveat that it works if you have a normal GI tract function, if your baseline is normal underlying all this. Now, some kids, there's different issues that arise, and the next step kind of in the hierarchy is a nighttime drip. Now, the goal is that you do a nighttime drip. The kids are not going to eat breakfast. You've dripped them all night long. They're not going to eat first thing in the morning. But the idea is if you've gotten them the calories, they have a gap, there'll be hunger later in the day, and perhaps you can have them, again, try to do some calories orally, work on their feeding skills. Again, more GI tract dysfunction, you start to think about continuous drip feedings. Here there's a hierarchy. You start off with gastric. If they're not tolerating gastric, then you go to jejunal. Of course, continuous drip, you really don't get hungry. If you're fed all the time, hunger doesn't really happen. The GI tract, dysfunction, motility, short bowel syndrome. If there's dysmotility, you use it low and slow is what I tell our residents. You use the motility you got as much as you can get. And the other thing is with short bowel syndrome, by dripping it low and slow, what happens is you end up using the absorptive surface area continuously. If you don't have much area, you need to make it work all the time. And so you make it work all the time by dripping it. All right. Again, this is from some of the safety things. And this is something that you're going to see a lot more of because one of the big initiatives is patient safety right now. Every enteral nutrition order should contain these 4 items. And a lot of electronic medical records now, I think is good, are driving folks to try to put this in every enteral nutrition order. Make sure it's the right patient. The formula details. What formula and what strength of formula. Delivery site and device. Where is it going in? How's it going in? And method and rate. My wife is a dietitian. I guess I should have given that as a disclaimer. And a very smart and a very good dietitian. And she worked in a home care company for a while. And she would get orders, and I would hear about it secondhand, that says increase rate to 42 meals an hour. And they're kind of like, okay, which patient? Because they get these in the fax machine. Which patient? Which formula? What site? And so that order leaves a lot to be desired. And it basically sets you up for errors. Okay, it's from this doctor, so it's probably this patient. It's probably the formula they're on right now. And so basically for safety, when you write an enteral nutrition order, you really should include all 4 of these points. Enteral feeding things, what do we feed them? Well, in pediatrics, we have human breast milk, we have infant and premie formulas, we have pediatric formulas, and last I'll talk a little bit about the blenderized whole food formulas. What to feed? Well, under a year of age, obviously, we think about breast milk or formula. One of the nice things about that is we can increase the formula density if we need to. And also there's some specific formulas for specific diseases. Now that's a little bit beyond the scope of my talk. I am not a metabolic specialist. I am a gastroenterologist. My world is brown and white. Okay. Over a year of age, the standard is a 30 calorie per ounce formula. Again, for hospital standards, preparation of formulas, they recommend using sterile water. Hospitals now have formula kitchens, and there's been some things that have happened when the formulas are mixed at the bedside. The nurses used to do this. You would see cans of formula sitting on the, in their prep area, and that formula would be used for 2 or 3 different patients, and it wasn't always sterile, and it had been there a while, and maybe it had expired, and so now they have special formula kitchens, and they have special trained staff to prepare formulas. Once it's prepared, it's good for 24 hours. It's to be refrigerated within an hour of preparation. The amount of formula that should be dispensed is that required for a 4-hour interval or a bolus feeding. Basically, when you're ready to use it, you warm it in a bottle warmer or warm water shortly before use. You don't let it sit for hours and hours and hours and hours because, not only is it good for growing infants, it's good for growing bacteria. All right, so when we think about formulas in the general categories, of course, we think about polymeric. And those are your complex proteins, standard proteins, fats, and carbohydrates. It's the cheapest, and most are milk-based. Why do most formulas start with milk? Well, it's a cheap starting material. And there's plenty of cows in Milwaukee, right? Wisconsin. We have some folks here. Where's Praveen? Praveen was telling us that they actually serve milk with dinner in Milwaukee. So it's like a standard fluid. The happiest cows come from Wisconsin. Then we have semi-elemental, and those are some predigested or tripeptides, and some of these have medium-chain triglycerides, okay? So it's semi-elemental. And then there's elemental, and there are formulas that are amino acid-based. And then there's our modular formulas. Now, you guys are probably all too young to remember modular stereo systems. That's when you had like a receiver, and then you had like a plug-in. You'd have a CD player and a tape deck and a turntable, and you'd plug in the modular pieces you wanted to play through your stereo. Anyway. So let's talk a little bit about infants specifically, all right? Well, here is the latest report card. 2011's what's out. Breastfeeding report card, Centers for Disease Control and Prevention. 75% of mothers initiate breastfeeding. That's not bad. That's not a bad number. But only 44% are breastfeeding any at all at 6 months. Only 24% are breastfeeding any at all at 12 months. 35% and 15% are breastfeeding exclusively at 3 and 6 months. 35% exclusively at 3 months. So some are still breastfeeding, but it falls off very, very quickly. And there's a lot of reasons for that. Human milk, well, that's, we're humans. We feed our young from mammary glands. We're mammals. That's why women have breasts, actually, is for infant feeding. It's not for Victoria's Secret. I mean, it's seriously. Human milk contains colloidal suspensions of casein molecules, fat globules, live cells, all sorts of fun things. It probably has some immune function. What's interesting is the whey-casein ratio in human milk. Initially, it's 70 to 80% whey to 20, 30% casein, and then actually decreases over time to 50%, 55% whey and 44% casein in mature milk. Of course, you guys are all aware human milk is deficient in iron, vitamin K, and vitamin D, and the deficiency in the infants can occur. So everybody gets vitamin K at birth. Vitamin D supplementation is recommended until the infant's weaned. Iron supplementation, should start at 4 months with oral iron and continue until there's adequate iron from foods. And this is one of the arguments about, when should we start solids in an infant. This is why some people say, well, if they're concerned about iron, you should start solids at 4 months. If you're concerned about allergy processes, you say 6 months. And nobody's really studied it or looked at it in depth. There's no literature to help us here. Benefits of human milk. This is a compilation, but basically there are studies that show us that human milk will reduce otitis media, nonspecific gastroenteritis, respiratory tract infections, atopic dermatitis, asthma, obesity, type 1 and 2 diabetes, leukemia, sudden infant death, necrotizing enterocolitis, you know. So human breast milk, and it's too bad that reflux isn't in this list. It's one of my pet peeves. Prematures. Now, this is a little bit different category, you know. If you're preemie, well, you have a little bit higher needs because you're not connected to that umbilical cord anymore. And so it doesn't meet the calorie or micronutrient needs of a premature infant. So basically, there's modulars or fortifiers now designed to be used in kids who are premature. Now, ideally, you'd add that to human breast milk so you get your immune benefits, and you do that, of course, in a specially designated area. Again, same concerns as we have with the formulas in the older kids and the older infants. Where possible, of course, they recommend using liquid fortifiers. Unfortunately, most of them are powdered. Because of the powdered formulas, even the fortifiers, now there's worries about contamination. Breast milk has a 4-hour maximum hang time because the human breast is not a sterile field. It's not a sterile product. It's usually given at a syringe pump that's a 40 to 60 degree angle. That's because of some concerns about separation. And it requires a new feeding setup for every feeding, new syringe and new tubing. And again, these are from the safety guidelines. Premie Formulas for those kids who aren't on breast milk, the standard is 22 calories per ounce. Most of them come liquid, ready to feed in the hospital. They have a higher protein, higher fat proportion of MCTs, and of course, increased calcium and phosphorus. And we've already kind of heard a lot about calcium and phosphorus in these kids. Premie Discharge formulas, standard is 22 calories per ounce. Either it's a powder or ready to feed, since for the parents making a concentrate is very difficult to make it 22 calories per ounce and something that the parents can actually do in a reliable fashion. Most of these families, for these premature kids, you know, most of them don't have a PhD or an MD or have not done a fellowship in pediatric gastroenterology. So most of them are powders or ready to feeds. Again, these have a higher calcium and phosphorus ratio. Nutrients between the hospital premature and term formula, they're very similar but not quite exactly the same. This is recommended. How long do you do a Premie formula? The recommendations are to a corrected age of 9 to 12 months, or the weight for length is above the 25th. Polling question, loading the poll. Here we go. Which is not an absolute contraindication for breastfeeding? Not. I know. They always tell you when you write questions, don't do a not. All right? But some questions is just too hard not to do a not. All right. Are you guys eating or are you polling? We have our delay. Internet is slow here. All right. Yeah, we're up to 5. See, we have this 12. We haven't even hit our peak of 16 yet. All right. Yeah, there it goes. All right. Well, we're at 16. Either that means only the rest of you are eating, and the other thing is probably the rest of you don't have smartphones. All right. So here are the contraindications to breastfeeding. Infections, HIV. Now, this is relative to the U.S. In third world countries where the kids are very likely to be infected at the time of birth, they recommend breastfeeding because that way the child will get the protective immune factors from the mother's breast milk. In the U.S., where there are good alternatives, the delivery methods are very good. They're unlikely to be infected at birth, so the recommendation in the U.S. is that HIV is a contraindication to breastfeeding. So that's relative to where you're at. HTLV infections, active pulmonary tuberculosis before 2 weeks of treatment, inborn error of metabolism such as galactosemia. Maternal drug use is a relative contraindication depending on the drug. Of course, our government actually has done something helpful. Okay. By the way, you know, it's April 28th, so you guys all got your taxes in, right? 17th. Anyway, something helpful. They have LactMed. This website, you can actually look up the data, and the latest data, which is updated fairly frequently, on drugs and breast milk and the risk and the benefits and all that, and find the data that's available on drugs and the content in maternal breast milk. Very helpful site. and it's done by the NIH. Donor milk. This is interesting. This is one of those things that's, I guess, one of those, we live in the new millennium. Now, there are donor milk banks. And what's interesting is most are nonprofit, but there's actually one in California that's a for-profit milk bank. For-profit. There are protocols from the Human Milk Banking Association of North America, follow the U.S. Food and Drug Administration and CDC recommendations. They're standards for cleanliness and storage. They're all tested for these infections, and they're all pasteurized. Now, that does affect the immune function of it, but on the other hand, you still have all the other benefits of it, even if it's pasteurized. So that's especially the neonates. This is the way that our neonatology colleagues are going. Now, obviously, this is not enough breast milk available even in these banks that if you recommend it for every kid who has like a risk of atopic disease, there's just not enough available at this point. So even though there's some data about atopic disease and breastfeeding or allergic diseases, just not enough, and not enough available. Human milk handling, you wash your hands with soap and water. It should be hand expressed or pumped. Use it in a glass or hard plastic container. Frozen if not used within 32 hours. Label the date and time collected in single feed aliquots. Once it's frozen in the conventional freezer, it's good for 3 to 6 months. You thaw it rapidly is what's recommended in lukewarm water. Never refreeze it. That's the reason they recommend doing single feed aliquots. The breast milk experts say you put it in a month they're going to need. You use that much. If you don't use it, throw it away. Don't try to refreeze it. Basically, all it does is break down the immune content, and once it's been thawed out, you start to get the bacterial growth in it. Infant formulas, historically, in the 1970s, there were lots of formulas. Everybody had a formula. Formulas were profitable. If you had some money, you didn't have to breastfeed. You could formula feed your baby, and so everybody had a formula. Then what happened is, in the 1970s, there was a soy formula that came out and it was deficient in chloride. And there were several deaths linked to that. And so this is one of the times when the government steps in and the 1980 Infant Formula Act, which revised the FDA original act that created it, and basically it said, we're going to regulate infant formulas and we're going to establish infant normals, what the ranges should be. Now, I will tell you that the ranges that they use, some of them are based on a little literature. Most of them are based on what breast milk supplies. That's where they got their data, because it's kind of unethical to do kind of a randomized trial. We're going to give half this and half none of this, and some of these studies would be very hard to design. How do we start? How do we choose an infant formula? You start with a standard formula. If it's not tolerated, you determine what the cause of the intolerance was. Change to a formula that will treat it, assess the response, and decide if another formula change is necessary. How many of you see what I call kids who come in and have formula roulette? Okay. Oh, we did a can of this, we did a can of that, we did a can of this, we did a can of that. Yeah. And I try to discourage this, but we see a lot of families and a lot of kids who do formula roulette. When we think about infant formulas, of course, we think about proteins, and we divide them into the big four: cow's milk based, again, happy cows from Wisconsin giving us cow's milk, soy formulas, casein hydrolysate, and the amino acid based formulas. Infant cow's milk, you can find them anywhere, cheap starting material, and they're constantly being tweaked. It seems like, you go 6 months and there'll be a new cow's milk formula with a new label. Sometimes it's the old one with just a new label, but they're constantly tweaking it, They change the logo, change the marketing, change the can. Soy formulas can be used for vegans, galactosemia and hereditary lactase deficiency, which is extremely rare. No proven benefits in colic or fussiness, and there actually is a fairly high crossover cow's milk protein allergy. Fairly high crossover. They are not, our infants are not Holsteins, and they are also not soybeans. Hydrolysate formulas are the first line for formula protein allergy. The NASPGAN reflux guidelines, you guys are aware of this, right? Have found that the data supports that a high number of the kids who have severe reflux actually have formula protein allergy, and they recommended a 2-week trial of a hydrolysate formula, a low allergy formula. And there's some data as well about some of these hydrolysate formulas and the prevention of atopic disease in the long run. And if they don't respond to hydrolysate, then you think about an amino acid-based formula. This should be a logical progression. Did I skip a slide? Yeah. All right. So carbohydrates. The carbohydrates in our formulas, of course, most of them are lactose. The cow's milk ones are lactose. Most mammals have lactose as the main sugar in their breast milk. Human breast milk, it's mainly lactose. Kangaroo, it's mainly lactose. Bears, it's mainly lactose. Tigers, lions, whatever, it's mainly lactose. There are some hydrolysates that use sucrose, white table sugar, and there's a few that use glucose polymers. In galactosemia, you do use the soy formulas because they don't contain lactose. And then here are the formulas that contain sucrose. Alimentum and the soy formulas except the Prosobi. Fats. We've heard some of this before. The main fats in most of the infant formulas are long-chain triglycerides. And there are some that have some MCTs. When are those beneficial? Again, when you have some sort of impaired fat absorption or lymphatic abnormalities, cystic fibrosis, short gut syndrome, protracted diarrhea, that's when you start to think about your MCTs. And here's the percentages. Okay, Alimentum 33, Progestamel 55, Elecare 33, Neocate 33, Porgin 87, and Vital HN 45. And those are the ones with the higher content or higher counts of MCTs. DHA and ARA. Now, every single infant formula now contains these two compounds. Long-chain polyunsaturated fatty acids, they're present in breast milk, but they were not in formulas. And so then some folks did some rat studies, okay, showed increased visual acuity and neurologic development. And there are some infant studies, small ones, that say maybe that works in infants too. Well, they're present in breast milk, so there's no harmful effects. So basically, one formula company put it in their formula, and now everybody puts it in their formula, okay? So, based on some of this, in about 15, 20 years, we're going to have a bunch of geniuses running around the United States, displacing us from our jobs. All right. In a way, we're doing what we're doing is a huge, we're doing the rat experiment on a huge basis here. All right. Probiotics. Probiotics, good bacteria. There's now formulas that contain probiotics. There's some evidence of decreased infectious illnesses, especially diarrheal illnesses in kids who are on probiotics. Again, these are there's some studies, there's some suggestions, and so we'll have to see. What'll happen is, like everything, when we start doing it in a large-scale basis, we'll find out actually if there's a real benefit or if this was just some epiphenomena. In thoughts, some newer literature that's just come out. Infant formulas are made 20 calories per ounce because breast milk they thought was 20 calories per ounce. Infants need more free water. The kidney function's immature. So, the older kids, we make it 20 calories per ounce, but the infants need a little more free water. And the increased caloric density in infants increases your risk of dehydration. However, there are some new studies coming out that show that the actual caloric content, the average caloric content of breast milk may be actually slightly lower. I've seen one paper come across that says it maybe is 18 calories per ounce. Now, that sounds pretty subtle, but you know that the growth curves tell us that the growth is different in breastfed versus formula-fed. And if you're getting an average of 20 calories per ounce versus an average of 18 calories per ounce, that may make a difference. And so we'll see. I'm just putting this on your radar, that I've seen some studies coming through this, reviewed some, and so we may find out that that may be one of the issues. You can underdilute to 24 calories per ounce for a kid who's failing to thrive, and you really don't get into much trouble with that. After that, you start to need supplementation because you're really kind of getting skewed as far as your content when you underdilute a formula. And most of the time what somebody does is add a modular to that, protein, fat, or carbohydrate modular to the formula when you're trying to boost the caloric density. Again, more in thoughts. Infection reports, you guys have all heard about the Enterobacter Sazaki infections from powdered formulas. Powdered formulas are like most foods. The food your mom made for you at dinner time was not sterile. It was clean, but it wasn't sterile. Most of the foods we eat are not sterile. If we cultured that turkey wrap, it's not sterile, okay? It's clean, but it's not sterile, all right? Infants, though, some of them, they've had some reports of some infections because of that. and 4 to 6 a year is what the CDC is saying. Now, unfortunately, because this is on the radar screen and the microbiologists have become involved and they started to study this bacteria a little more, just FYI, Enterobacter Sazaki is now Coronobacter Sazaki. Just when you figured it out and it was safe to go back in the microbiology field, they renamed it, all right? So when you start seeing Coronobacter Sazaki, it's the same bug. All right. Metabolic formulas, there are some specific formulas for specific diseases. There are carbohydrate formulas for kids with carbohydrate disorders. And then you have to go add a carbohydrate. This is what they call one of the modular formulas. So if you have a child who has, some sort of difficulty with this, galactosemia, you may be able to add fructose as the sugar to that formula. So those are modular formulas. There are some modified fat formulas, reduced mineral formulas like Calcilo for kids with who have calcium disorders. Again, most of the time you end up having to involve one of your metabolic specialists to get to those. Complementary foods. I've already mentioned this. The recommendations are really fuzzy because there's almost no literature. Most folks recommend exclusive breastfeeding or formula 6 months of age because of the whole allergy concerns. The literature that shows if you introduce complementary feedings too soon, you have an increased incidence of autoimmune diseases and atopic dermatitis and all that. But of course, the iron folks would say, well, if you're worried about iron content, you need to start the solids at 4 months of age to get their iron up. So this is really fuzzy. Most people talk about cereal, single ingredient solids, and it's funny, if you look at the American Academy of Pediatrics recommendations, they have this range, 4 to 6 months of age. And again, no literature. So you have these different camps. You have the breastfeeding advocates, the lactivists, who basically say, hey, nothing until 6 months. Then you have the folks who are concerned about anemia and iron, and they're saying, oh no, 4 months. And since there's no literature, they hedge and they're politically correct and they say 4 to 6. Pediatric formulas, I have a case. KC, it was JC before and it was KC now, okay? Casey's a 13-year-old that presents with newly diagnosed Crohn's and mild malnutrition. What form of nutrition supplementation would you start? And I hadn't heard your talk, so, and this this is not fair. All right, so what form of nutrition would you start? Okay, mild malnutrition. All right, I was going to say, and how many of you would think about parental nutrition? Yeah, nobody's going to raise their hands now. How many of you would think about some sort of tube feeding? She's mildly malnourished. Depends on how bad she is and how bad her disease is. And how many would you think about supplements, oral supplements? Certainly, absolutely, you think about some oral supplements. She develops a stricture. Oh, rats. I hate it when that happens. And requires surgical resection of an ileum. Post-op, she has difficulty tolerating standard feedings. What enteral interventions could you try? Any ideas? Well, some of the things you could try, things that affect motility and emptying, you might go to something a little more elemental, for instance. Sometimes that'll empty a little better. Sometimes if she has tolerating feedings, if it's a motility issue, you might think about a pro-motility agent. So there's a lot of different things you have to think about and try. All right, pediatric formulas. Most of them are 30 calories per ounce, as I indicated earlier, but some are 45 calories per ounce. You still have to meet free water needs. It's interesting. We see kids who have, heart disease, for instance, and their parents want them to gain and grow, but some of these kids after heart surgery, they have poor motility, they tolerate feedings poorly, and the parents come in and say, well, why can't you do 50 calories per ounce? And then you have to explain to them that water is a nutrient. You have to meet free water needs. You cannot make this so concentrated that it's basically syrup. Of course, also the pediatric formulas have the higher vitamin and mineral levels to meet the pediatric reference intakes. Yeah, they switch from RDAs to RDIs on me. I still want to say RDAs. Of course, we start with oral supplements. First line, increased caloric intake. Of course, they're sweetened with sucrose to enhance their taste. They got to taste good or the kids won't do it. Some are ready to feed, some are powdered, some are reconstituted with whole milk. And it's funny. This is where I will do roulette. It's interesting how one child will think something is the greatest thing in the world, and the next child won't drink it at all. And so this is where I will do all that. I will actually sometimes give the parents a few things to try. And it's like, okay, tell me which one they like the best. Because in a way, it's the calories. It really is the calories in many ways. Standard cow's milk, again. Even here, it's standard cow's milk, widely available, cheap. Some of these are going to do tube feedings, unflavored, will lower your osmolarity. Most of these are lactose-free. Now, these are the kids where you have a potential for lactose intolerance. Infancy, it's very unusual, but in childhood, you start to see more lactose intolerance. It's 12% of the general population is lactose intolerant. Fat mixtures, of course, it's a mixture of long and medium chain triglycerides, and it depends on which formula you're on. Polling question. Okay. A pediatric formula that contains peptides as a protein source is indicated for, everybody vote. Get your smartphone out. Oh. All right. Well, let's talk about these peptides. Wow, still going. 15. We usually have 16. Did the other person go to the restroom? No, 17. Somebody either voted twice. All right. All right, a pediatric. Now, the key here is I told you pediatric formula contains peptides. All right. The tripeptide formulas, they're not designed, keyword here, it's kind of like before I said, like talking about the NG placement. The only documented way to verify placement is a chest X-ray, but we worry about radiation. We don't say, you don't want to get a chest X-ray every time you turn around. They're not designed for allergy or malabsorptive conditions. They have much better emptying. They're much better tolerated. They contain a percentage of their fats as MTT. All right. Now, not designed for doesn't mean they aren't used for allergy or malabsorption. Semantics are so important. Do you love me? Oh, I really like you. Semantics are very important. All right. Elemental pediatric formulas. There are also some of theirs out there. They're amino acid based. None of these have a high MCT, which taking care of short bowel kids and some of the kids with liver diseases, I wish there was one with a little bit higher MCT out there. Maybe not all MCT, but a little bit higher. Use them for allergic conditions? Yes, they do get used for allergic conditions, but a lot of them aren't designed for that. They're designed for malabsorptive things. Short bowel kids, better emptying and absorption immediately. It's interesting. We have some kids who have short bowel syndrome, but that bowel's somewhat dysfunctional. It's short, but it doesn't work all that well. Especially gastroschisis kids have very poor motility, and we end up fighting, and they don't empty very well, even though they're short. Absorption immediately. I like to tell the residents, that when we take care of these kids, it's like, okay, I don't want them to have to break it down. I just want them to grab it as it goes by. Okay, it's the same principle as using it low and slow continuously, so it's always in contact. That gut lining is always working. Fiber. Here's some more enteral feeding questions. Fiber. Yes, no, what to do? Does it help? Yes. Well, it helps with stooling issues. Certainly it does. Of course, there's still some black box things about kids and fiber. Soluble versus insoluble, which is better? When should you use it? Should you use fiber in short bowel syndrome? Should you use it if they have a colon? Should you use it if they don't have a colon? Should you use fiber that's soluble if they have a colon? Or should you use insoluble fiber when they have a colon? And a lot of this is trial and error and experience. Okay? No, I can't. And I can tell you that we have started a short bowel clinic at Le Bonheur in Memphis, and this is we're prospectively setting up our trials now that we have a clinic. And one of the things I want to answer is some of these questions. It's like literally, let's look at this because the literature's all over the place, and it's all anecdotal and it's case reports. Transpyloric feeds. This is one, also I tried to set up a study a few years ago to do this, and didn't get very far. But when the feed is transpyloric, I was taught the dogma that if it's beyond the pylorus, you're skipping the stomach, and it needs to be at least elemental. Okay? How many of you were taught that or taught that? Not many. Okay, so you're younger. Yeah, all right. Thank you, Sam. I was taught that, okay? Now, what does the literature say about transpyloric feedings? What does it actually say? Well, there's actually a few studies that show that tolerance is okay. Actually, non-elemental is tolerated okay. It doesn't have to be, it can be polymeric. But there are several animal studies and some loop studies and some studies looking at absorption, and the elemental in the transpyloric feedings, the absorption's much better for a transpyloric feeding. So this is an area that somebody needs to study this. We don't know. If it's past the pylorus, does it need to be elemental? When is an adult formula okay? All right. When is it okay to use an adult formula? Well, adolescents? Well, but adolescents have the highest calcium and phosphorus needs in the entire lifespan. So the calcium and phosphorus, then you end up supplementing their calcium and phosphorus to meet their calcium and phosphorus needs if you're giving them an adult formula. Now, the adult formulas do contain a higher protein content, which is pretty good for an adolescent. So adolescence is where I start to think about an adult formula, but again, I always keep this in mind. There is no pediatric immunomodulating formula out there, all right? There are some formulas for adults, which is why this followed the adult formula comment, that have immune modulating characteristics, especially some for burns that are designed for adults with burns. Formula for inflammatory bowel disease was actually on the market for a while. Some of you remember it. How many of you remember a few of you remember that. It contained transforming growth factor beta. And again, talking about enteral nutrition for inflammatory bowel disease. It's gone. Why is it gone? It didn't sell. It got old on the shelves. It didn't get used. There are some formulas under study right now using the omega-3s. We talked about that a little bit. Especially formulas for specific formulations. There's a ketogenic diet. There's formulas for fat transport defects as well. So again, a variety of things. Some of those you have to involve your neurologic colleagues. Neurogenic colleagues? Anyway. Old-fashioned system. Delivery systems. Let's talk a little bit about delivery systems. You know, talking about enteral nutrition, you got to talk about the formulas, you got to talk about safety, you got to talk about orders, a bunch of things here. It's kind of like a potpourri of lunchtime. The old-fashioned thing was cans. Everything came in a can, you know. It was all canned. And you had your pop tops, you know. You had your six-pack of Pediatric. You know, get your 6-pack of Pediatric. And, you know, the bags, you decanted into the bags. You had an ice pocket on the outside for the extended drip feeds. And in theory, those were good for 24 hours. Now, what's come out is available are closed systems, all right? No infant closed systems available yet, but a closed system. It's sterile inside that bottle. You tap into it with a sterile tubing system, and you put it right in the patient. It's great for immunocompromised patients. Wonderful for bone marrow patients, those kind of patients. The manufacturers have great data. It's good for 48 hours, but no manipulation. You don't do anything. You can't add salt to it. You can't add, you know, anything to that formula, or you screw up the sterility, all right? But it's great for immunocompromised. So the hospitals like it because basically the tubing is good. You hook up the tubing, you're using one tubing set for 48 hours. You're not changing it frequently. So this is a cost savings for them. You get a bottle of formula and you hang it. If it's a closed system, you can use it for 48 hours. Blenderized formulas. There is one blenderized regular diet formula for pediatrics that is commercially available. It is made from quote-unquote regular food, is blenderized. It has been studied. It does contain a complete nutritional profile. All right. The patients, of course, perceive this as much better because it's from regular food. That's just a parental perception. Of course, any of these blenderized formulas, unless the commercial one, has the potential to be incomplete without guidance. There are resources available. There are some folks who have done this, some dietitians I know of, who have worked out some very careful recipes. Again, these families think this is better, though. They perceive it as better. But the families that do this, the moms actually admit to me, they spend all day preparing these formulas and feeding it. Yes, they feed it. It takes all day to prepare. It takes all day to feed. It's like a job, and it's for these moms, but they perceive it as better. So, again, honestly, the study on the formulas are that they grow and gain just fine with them. If the family wants to do this is kind of like some of that complementary medicine thing. The family wants to do this. I want them to tell me, though. I want to be involved in this. I want to make sure they're following some of these carefully worked out recipes and guidance so that the kids are getting nutritional complete intake. I don't want them to hide it from me. Fortunately for me, I'm not a very intimidating person. And so families will tell me, and I'll ask them, and they'll talk to me about it. Like I said, if I want to know. I don't want to be in the dark.